Today we are going to talk about inserting a nasogastric tube. There's going to be two different reasons why you may insert a nasogastric tube into a patient. One would be for feeding, and the second one would be for gastric decompression. Obviously, feeding is going to be feeding your patient food. It's not going to be like a cheeseburger ground up with a blender. It's going to be feeding tube, feeding formula for your patient. And decompression can involve, like, if your patient has had surgery and they may have bleeding into their stomach, or if they have some obstruction in their colon or in their small intestine and you need to get some of those gastric secretions and other goodies out of there, you can remove contents from the stomach with this tube. So these are the steps that we're going to go through. You're going to first assess, then you're going to prepare. This is both preparing your equipment and preparing your patient. Then you'll do the procedure, you'll check the tube placement, you will anchor the tube, and these are just finishing up things. So first, when you walk in the room, let's assume you've already done patient privacy, hand hygiene, assured that this is the right patient that you're supposed to be working on, and checked the orders and the MAR from the doctor. So you're going to be checking in, like when you check into the computer system, for what type of tube the patient is going to be receiving, whether it is a feeding tube or a decompression tube, and also the schedule. So should the patient have continuous suction on a decompression tube, or is it feeding at once, like for once every 8 hours, or what's the schedule for that? You're also going to be taking your patient's vital signs. I mean, we know that the normal vital signs are like taking your patient's temperature, taking your patient's respirations, listening to their heartbeat, like listening for their pulse and stuff. But there are specific vital signs that you really want to focus on with this particular procedure, and that would be O2 saturation, lung sounds, and respiratory rate, like if they're having to struggle or if they're having to use accessory muscles. You want to take their O2 sat because you want to make sure that your patient is well oxygenated and that it doesn't change greatly during the procedure. You also want to take their lung sounds to make sure that if they have crackly lung sounds to begin with, that they don't necessarily improve, but that they don't worsen. So if your patient starts out with clear lung sounds, you want to have clear lung sounds when you're completed with the procedure. These vital signs are giving you a baseline of where you're starting off. So along with those vital signs, you're checking your patient's mental status. You can do this by just talking to them and seeing, like observing them, seeing how they're interacting with you and any other assistants you may have in the room. You're also going to use a tongue depressor to press down on the tongue and test your patient's gag reflex. While you are in the mouth, you can check to see if there's any obstructions, like you're looking in the mouth, but you're also coming up here and looking at their nose. You can check their nares, check the patency. You want to see if there's any obstructions. You can use your pen light to actually look up there, but you can ask your patient to hold down one nostril and breathe, and then do the same over here. And you can ask your patient which nostril feels more clear. They might be able to tell you that answer. You can also ask your patient if they know if they have a previous history with any nasal trauma or any nasal surgeries. Sometimes the patient has been hit in the head with a baseball bat and it broke their nose, or they might have had surgery for a deviated septum. These are things that you want to know beforehand, just in case this should change or alter the course of how you insert this tube. Along with checking their nose, you're going to it's not really your nose, but along with checking your patient, you're also going to listen for bowel sounds. You don't want to insert an NG tube that's going to be for feeding them if this patient doesn't have any bowel sounds. I mean, that could be not included. It could be normal with a patient that is using this for gastric decompression, but you don't want to put more fluid into a body that is not able to get rid of it. So if the patient doesn't have any bowel sounds, there's a chance that things aren't working properly down there. So if the patient doesn't have any bowel sounds, you have to wait. You actually have to listen for 5 minutes for each quadrant. There are 4 quadrants, so you have to listen for like a total of 20 minutes. But listen for bowel sounds. If they're bowel sounds, then you're good to go. So now you're going to explain to the procedure to your patient, let them ask any questions if they have any. The equipment that you're going to need for this procedure, for the patient and the patient's comfort, you're going to need like a bath towel that you can drape over the patient's chest. You'll need a basin. Our instructors told us not to use one of those tiny kidney basins, which I think they call an emesis basin, but rather use one of the pink tubs that the patient may use, that the nurse may use during a patient's bath. Just because, especially if a patient is getting this for gastric decompression, they may have a lot of fluid that may come up, so you want to have a bigger basin to catch that stuff. You'll also want to have a glass of water and a straw. This is vital to help encourage that reflex of having the patient swallow and get that tube down. And you'll also include some tissues should your patient need them. For the actual procedure, you'll need the tube, whether it is an NG tube for gastric decompression or an NG tube feeding tube. You just get the appropriate one. You'll also need lubricant to lubricate the tip of that tube. You'll need some tape. Typically, it's not the paper tape, but it's like the, I don't know what it's called, but it's not the easy tear paper tape. It's a little bit more structured and it can stay onto the patient. This is going to be used for securing the tube to the patient's nose when we're done. You'll need a syringe with a catheter tip. This is one of those needleless syringes that you're going to put onto the end of the tube. You'll need your stethoscope and you'll need a tongue depressor. So there's 3 different positions that you can put a patient in, and it depends on the patient's state. So the first one is if your patient is just normal talking, just talking to anybody, awake, alert, fully conscious, then you're going to put them in high Fowlers. That's going to be 90 degrees. It's sitting upright like this. You're going to be putting the patient into these positions as tolerated. So obviously, if your patient gets to like 85, this is a really bad example, but if your patient gets to like 85 degrees and they're like, ow, 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 don't go any further. But you don't want to have your patient completely laying down straight on the bed. So that first position is high Fowlers, and that's for patients that are fully conscious and awake and all that jazz. The second position is semi-Fowlers, and this is for a patient that is comatose. And then the third patient, and that's 45 degrees. So Fowlers is 90 degrees. Semi-Fowlers would be 45 degrees. That's for the comatose patients. And then should you have a patient that needs to stay supine, which is just straight laying down, like we talked about this in lab today, like if a patient had surgery on their femoral artery, or if they broke their back and their spine has to be stabilized a certain way and they have to remain laying down, let's say that this is their head and this is their foot, then you would put them in reverse Trendelenburg, which would be head up here, feet down here. And I'm actually going to see if I can find a doll to help me with this. Okay, so you're going to laugh, but this is one of my niece's favorite little toys. She carries this thing around with her everywhere. I think it's from like the Hunchback of Notre Dame. Okay, Notre Dame, whatever. Okay, so for a patient that is fully conscious in the bed, you're going to want them to be, I mean, he's not going to bend right here, but let's just imagine that like this is his hip. You have your patient sitting upright. This is high Fowlers. If your patient can't tolerate that, or if they are comatose, then you can put them in semi-Fowlers, which is 45 degrees. And then if you have the patient who like broke his back or like had surgery and they have to remain laying down like this, you'll put them in reverse Trendelenburg, which is head up, feet down. We experimented today with our hospital beds to see at what degree the patient would start slipping down out of the bed. And I think we said it was probably like 25 or 30 degrees. So obviously don't tilt the bed so much that your patient like slides straight down, because I mean that would be bad. So those are the 3 different degrees and levels where you can place your patient. So the next thing that you're going to do, I mean, we might as well use our little guy here. You're going to be measuring the tube. So the tube comes in like a standard length or whatever, but it does come in different diameters. They call these Frenches. The doctor should prescribe or should state like what French he wants to use. If not, check with your instructor or something. But the first measurement that you're going to do, and I'll see if I can show it with this doll because he's going to be my assistant right now. So the first measurement that you're going to do, you hold up the tube. So you hold up the tube and you start at the tip of the nose and you go to the front of the ear. Actually, it might be better if you saw it on this side because I think his ear is more visible. I don't know. So you start at the tip of the nose and you go to the front of the ear. From the front of the ear, you continue that measurement down to his xiphoid process. So it's about right here. On me, it's about right here. It's that bottom, like here's my rib cage. It's the bottom of this bone right here between your rib cage, like between the sides of your rib cage. So you start from the tip of the nose, you go to the front of the ear, from the front of the ear to the xiphoid process, and at this point you add 5 centimeters to the measurement, just so you have a little bit more to go. You mark that, once you have that measurement, you mark that with a tiny little piece of tape. Or, a Sharpie, whatever you have. We have tape in our lab. I've seen some people carry around Sharpies. So once you have that measurement, then you take your needleless syringe with that catheter tip. You get some air inside of it, typically 10 to 20 mils, and you put that on the end of your tube. You don't want to be sticking that tube down somebody's nose and then something possibly comes shooting out. This is going to help prevent that shooting out idea. The next thing you're going to actually do the procedure. So at this point, you'll tell your patient, just try to relax. If you have an assistant with you, they can hold up the glass of water with a little bendy straw in it to help your patient encourage that reflex to swallow, and they can be like a cheerleader, say, yeah, you got this, you got this. So let's go back to this little guy, because why not? So you you lubricate the tip of the catheter, not the catheter, the nasogastric tube. Sorry, we just talked about catheters today in lab too, so my mind is all crazy, but whatever. So you have your patient sitting up and you have the tube and you say, okay, I want you to take deep breaths and I want you to keep swallowing. Initially, when you start off with inserting the tube, you choose whichever nostril y'all decide was best for it, whether one was less clogged or more patent or whatever. But to begin with, you're going to have the patient kind of bend their head back just a little bit. This is going to help encourage the tube to go to the back of the throat, and then you're going to eventually have them turn and put their chin going down. So I'll see if I can show it on me. Initially, they're going to start off like this, and you're going to insert the tube here. This whole time, you're telling your patient, okay, keep taking sips of water, keep breathing. This is going to help encourage this tube to go down. So you insert the tube here. Once you see the tube in the back of the throat, which you can use with your tongue depressor to hold down the tongue and check that out. Once you see it in the back of the throat, then you can tell your patient to bring their chin to their chest, keep drinking water with that little bendy straw, and then you can keep advancing the tube down slowly. You don't want to go super slow, but you don't want to go like shove, fast. You keep encouraging that tube to go down until you get to the mark on your tube, whether it's Sharpie or pen or tape or whatever. So at this point, your patient will have a tube just sticking out of their nose, and it's just hanging there free. So you need to get your tape. The way that we discussed this earlier is if you take your tape and if this was your piece of tape, if you cut or tear a little bit right here straight down to make it kind of look like pants. So imagine this is like a tear. Let's see if I can do this. You don't want it to go all the way through because you want to have this solid piece up here. But imagine this is a piece of tape. It's obviously not this big. You can use your imagination. Put a tear right here, and then this part right here will go on the bridge of their nose, and then you can use these little legs from this tape to wrap around the tube and secure it. That is a really bad idea of doing this, but hopefully I can find something to show you what to do with. But once this is separate, then this one will go this way, this one will go that way, and it'll help secure the tube to the face. Then you can put one last little piece of tape right here, over the bridge of the nose, to help secure that tape even more. Now, there are 4 different ways that you can that you can check the tube placement. The first one is using that syringe that we had filled with air earlier. So using your stethoscope, you will have the stethoscope over the stomach, so epigastrically, and you will very quickly advance that syringe to let that air puff into the stomach. Hopefully you'll hear it. If not, sometimes you might just have to try it again. Oops, I hit the table. So after you've done the little puff of air, the second check is checking the stomach secretions. So pull back on the syringe and aspirate some stomach contents. Your first check is here. You can check the color and the consistency of the liquid that you get in the syringe. If it's green and kind of liquidy, or like greenish, brownish and kind of liquidy, then you're in the right space. If it's brown and looks more like coffee grounds, then you got a whole other issue and you got to stop what you're doing and call your instructor or whatever. But you're looking for a green liquidy consistency, which is consistent with the stomach fluid. The next check could be will be the pH of that secretion. So you can take the syringe off and put a little bit of that gastric secretion into a basin and then test it with a pH strip. When you're testing this, if the pH is less than 5, that means you're in the stomach. So there you go. The final and like the end all be all placement check for these tubes is going to x-ray and having a radiologist confirm the placement of the tube. Typically they have like the radiologist with a little portable x-ray come up to the patient's room. So I mean, you don't normally have to take them down to x-ray, but you never know, stuff might happen. So once you've anchored the tube, you can also, once you've anchored the tube to the nose, you also need to anchor the tube to the gown, and if it's a suction tube for gastric decompression, you need to secure it to the bed. So you can secure it to the gown with tape or with like a rubber band and a safety pin. So like if you do the rubber band and safety pin, obviously don't poke the safety pin through the tube, because what's the point of that? So pretend like this is the tube and this is your rubber band. You just kind of like loop it around so that the rubber band is holding the tube, and then you can secure that rubber band to the gown, or you can just use like a piece of tape and see if that will hold it. You want to make sure you have a little bit of slack because the patient could turn their head or whatever. You don't want that tube to be like they can only stay like this. And then for the bed, especially if it's that decompression tube, there'll typically be like a suction unit on the wall that tube will be hooked up to. So you can take like a towel, put it on their bed, pretend like this is the tube coming from my nose down to holding on to my patient gown, onto my gown, coming up to my bed. So if this is my tube going to the wall, you can put that here and then just, you know, let's see if I can even do this, fold this over. That's like the worst fold of my life, but whatever. You can fold this little towel over and it'll help hold that tube there. And it's not like, oh, look at my gastric secretions that are being really removed from my body going into this tube. Like, you don't see it. It's just covered with a towel. So that's for like a decompression situation. Obviously, if it was a feeding tube, it's going to be hooked up to like an IV pole that'll have the feeding there. So once you have the tube secured to the nose, to the gown, and to the bed, accordingly, if you need to do it to the bed, you can finish up. You can get your patient into a comfortable position. You want to make sure that they are at least 30 degrees because they are going to be on aspiration precautions now, since they are receiving, whether it is food or decompression or whatever. We just have to make sure that we watch them and they're not like laying. We don't want them laying flat. We want them to at least be laying like this, or if they have to stay flat, stay straight, stay like this. You want to offer them oral hygiene, so like let them brush, like rinse their mouth out with some mouthwash or drink some water, get some tissues or whatever. Again, you're going to assess their vital signs. You're going to check their O2 sat and their lung sounds again, just to make sure that if they started off with clear lung sounds, you want them to still have clear lung sounds, and you want to make sure that they are still breathing okay and that the tube did not end up into their lungs and messing with their oxygenation. So you can also observe your patient for like difficulty breathing, or if they're continuously gagging, or if they're coughing, or anything else that might be a little red flag for you. You then will record the procedure, including the type of the tube that you placed, how well the patient tolerated the procedure, the length that you inserted the tube to. That's fun. So like, I did 8 centimeters, which you're really not going to do 8 centimeters. It'd probably be like 58 centimeters. You would record that because the tube can advance and come out, and you got to know, oh, well, it was at 58 this morning and now it's at 48. Well, what has Johnny been doing in bed? Has he been pulling that tube out? You got to know these things. You can also document like the pH value of the stomach secretions, the color and consistency, and if you confirmed the placement of the tube with the radiologist. So those are the different steps and little tips for inserting a nasogastric tube. Here's a little sign. I don't know if you'll be able to read it, but There's my fun little picture. And of course, once you're done with the procedure, like you get your patient back comfortable, you lower the bed, and you perform hand hygiene, because that's all you do is just wash your hands a whole bunch.